So the next talk builds off of that and goes right into transcatheter therapies. And again, disclosures, and I'm going to go fast through these because I have a lot of slides, but these can be boiled down into leaflet repair. Think of the mitral clip or PASCAL, neocord, other things. I'm not going to talk about all of them because I don't have time to. Then there's annular repair. Can you fix the annulus? This is actually a coronary sinus device and trying to pull the annulus up. There's chordal repair. You can put artificial cords in, which I guess that would be more where neocord or harpoon sits. Space occupiers, a balloon that you inflate in the middle of the mitral valve so the leaflets coapt around the balloon. And then there's TMVR, replacing the valve. There are at least 50 different devices out there. And every time I go to a new meeting, some guy comes up to me, I've got a new device. And so Mike gave a great talk earlier about the evolution of TAVR and these new devices that are very thoughtful. And they're thoughtful iterations of what ought to work a little bit better, much like SAPIEN 3, much better than the original SAPIEN, or the XT, or Evolut Pro, much better than the original core valve. But in the mitral space, we're not there yet. All of this, every single one of these things is new, unproven, and we haven't even gotten to the point of iterating them really to make them better. Again, we already went over this. You need to know whether it's primary MR or secondary MR. If it's primary MR and it's degenerative, you want to do surgery, and it's usually feasible to do that. If it's secondary MR, today the only proven therapy is coapt. But that's in a subset of patients. That isn't everybody, and we haven't really sorted that out. I already showed you this about surgical repair. I keep hitting that at every talk I give because I don't want people thinking you can bypass this and do a percutaneous approach. This is curative for the patient. It's the gold standard. So what about clip? Everybody, I think, knows the clip. It's changed. I mean, this is the old cobalt chromium with epigloy grippers. Now we have nitinol grippers, and we now have XT and NT and NTW wide, 6 millimeters instead of 4, and XTW, so all of that's coming. It's pretty cool. You already seen this. MitraClip is safe and effective, but not quite as good as surgical repair for getting rid of MR. More about that later. You know that it's approved for degenerative MR, prohibitive risk for surgery, and that has to be determined by a cardiologist and a surgeon experienced in mitral valve surgery. This was right when the FDA, I was involved in these negotiations. FDA, Abbott, me, Mike Mack, and Pat McCarthy in a room arguing about this and getting this language right. Turns out, we talked to Steve Bowling and McCarthy and, all these mitral valve surgeons, and how many of these centers are there in the U.S.? He said maybe 100. Bowling said probably 40. I think he's right. There's 275 mitral centers in the U.S. There are not 275 surgeons that know this, or that do minimally invasive repair with zero mortality like we do. So this is kind of a joke. But anyway, I'm getting off on a tangent. Here's what the clip looks like if you haven't seen one. It's really important. This is the key view. The view of the leaflets inserted all the way down into both clip arms, the grippers coming down and grabbing them, and then the next view, as you close the clip clockwise on the knob at the back, that thing starts closing up, that the leaflets don't pull out, because they can, and we've all seen that happen. So you're looking at all this, TEE guidance, critical for doing that, and then you get this tissue bridge at the end, double orifice, looks really good. This is a great technique, and we've gotten better and better. More about that in a minute. Worldwide, 75,000 patients. Even though it's approved only for DMR in the US, worldwide experience is mostly done in FMR. Why? I'm not going to show you the data, but there are tons and tons and tons of registry studies and observational studies showing it makes these people feel better, and it works. And so the US didn't approve it for that. Again, we got this spectrum of disease that we talked about earlier, where somewhere along on this spectrum, the ventricles are too bad and probably shouldn't do a clip. It's probably not going to help them. But on this end, it's going to help them a lot. MR correction's good. So we have to figure out the sweet spot, who we can help, who we can't. We don't have the data on that yet. But with that background, this trial just came out. Greg Stone presented it at TCT just 10 days ago or so, and it's a seminal trial. And so the thing I want to show on this slide, forget all of that stuff. This is just showing the high success rate of implanting a clip when you wanted to do it. It's very high. Look at this. This is really amazing. At discharge, 82% of the patients had 1+ MR. That is way better than has ever been reported in any US or European registry. So we had great clip operators and great technical expertise in this trial and great results. Only 5% of patients came out with 3 or 4+ MR. Vast majority 1+ or better. So what were the primary outcome, and this is important too, was all heart failure hospitalizations over 2 years. Okay, in the control arm, there were 283 hospitalizations and 151 patients. And in the clip arm, 160 hospitalizations and 92 patients, a reduction of 47%. Number needed to treat of 3.1. This is partner B-like. This is TAVR-like. This is dramatic. I mean, there's nothing in heart failure like that, where you treat 3 patients and you save a heart failure hospitalization. The other thing I need to point out about this trial is we counted all the hospitalizations. Most statistical models count when you look at these curves, you don't even think about, I don't think about this, maybe you do, but most of the time you're looking at time to first hospitalization. And that's what those curves reflect. We didn't do that because if you have heart failure, do you really care if the time to your first hospitalization was 1 month earlier or later? Or do you care that you had 10 hospitalizations in 2 years versus 2? I think the answer is obvious, and so we were trendsetters in this study by counting all the hospitalizations. Again, very important as we talk about other devices, the safety profile, 97%. So bad things happening to you during a mitral clip are uncommon. It's one of the safest things we do. It's super safe. And so that sets a high bar for any other technology. They have to be as safe as MitraClip. There were a whole bunch of secondary endpoints. The study was set up that if the primary endpoint was not met, none of these would be tested. And then they were in this order. So first we tested MR grade, then mortality, and so forth and so on. If you came down this list and anyone was not significant, you would not keep going. They were all significant. Highly significant. So this was unbelievable. And here's the mortality. Again, the control arm, mortality of 46% at 2 years, reduced to 29%, number needed to treat 6. Phenomenal. Game changer. Let's compare that to other therapies. So the number needed to treat for MitraClip, or let's just say the % reduction in mortality of 40% is the best ever. And this is on the background of all these other therapies. This is on the background of an ACE, ARB, beta blocker, Entresto, aldosterone antagonist, etc., ICD, CRT. Better than that. Wow, huge. Okay, so why is it different than the Mitra FR? We talked about that earlier, but I want to hit home again and again because people are going to ask you this. You'll have the answer now. Mitra FR had less MR, 0.3 versus 0.4 for ERO. 52% of Mitra FR had an ERO that we would call moderate at Houston Methodist or Baylor Dallas, and only 16% that had this specific finding for severe of 40. Also, the EFs were the same, but the ventricular volumes were higher. Now, let's make a point here. Years ago, I did the Echo Core Lab for the BEST trial. It was a heart failure trial. And the most important echo predictor of mortality was an end-diastolic volume index of 120 per meter squared. They're way above this in Mitra FR, meaning the ventricles are bad. And that's what's killing those patients, not the MR. But the ventricles weren't even near that in COAPT. Smaller ventricle, more MR, benefit. Huge ventricle, less MR, maybe not benefit. We're going to do further analysis to sort that out. But the other thing I want to point out is really down here, and that is the 12-month result of MR greater than 3+. 5% in COAPT, 5% at discharge, as I already showed you, 5% at 12 months, durable. In MITRA FR, 9% at discharge, 17% at a year, not durable. What does that tell you? I mean, they also had higher complication rates in the procedure. It tells you that if you have heart failure, severe secondary MR, persistent after optimally tolerated doses of medical therapy, don't go to France. Colin Barker will do your mitral clip. I'll do your mitral clip. Don't go to France. Yeah, you want to drink some good red wine, go to France. You want to see the Eiffel Tower, go to France. So mitral clip is good, but there's still some issues, and probably it's important to point out that in most trials, getting down to mild, 1+ or better, is about 60 to 70%. It was 82% in COAPT. Is moderate, leaving 2+ MR really good enough, and there's still 5% of patients, except in France, who still have severe MR. So it also reduces options for surgical repair later. And we look for a gradient of 5 or less in the cath lab, but I've seen patients where we walked out with a gradient of 5 and they get up walking around the halls, short of breath, we echo them, it's 10, you know, or 11. So we can cause mitral stenosis. This is the new kid on the block. It's called PASCAL. It looks similar to a mitral clip, but it has a spacer. So instead of pushing the leaflets together, the leaflets now coapt around a spacer. They're still, they call these things paddles and clasps instead of, they have different terminology, but it's a spacer, and this is kind of what it looks like on fluoro. We've done a few of these. Here's the pre, here's the post. Looks exactly like a clip, but it's not because of the spacer. What's shocking to us, that's how it goes, is two things. One is if you'll notice this is less stiff. It moves with the valve. And so a lot of people think that there's going to be less gradient with this device because it flexes a little bit with the valve. A lot of people think that will leave less stress on the leaflets, which may be good for durability. And in so far, a 60-patient early feasibility study, I've just seen the results, but I'm not permitted to show them to you. 15% of the patients have this at the end, trace or none MR. This thing seems to be possibly better than the clip at just completely getting rid of MR. We won't know that until we do a randomized trial that's being planned. Annuloplasty. So there's a lot of devices out there that propose to do this. I'm not a big believer in this. I'll show you why, starting with the anatomy. So these needle drivers are in the coronary sinus. Here's the circumflex artery. You pull that this way, you can pinch that off. Here's the annulus. It's far away from the coronary sinus. When the surgeon puts stitches in here and they can pull it this way, I'm not convinced that putting anything in here and pushing on it is going to really move it. And the CS doesn't completely encircle the annulus either. Valtech has a device that I'll show it to you, that has 6mm screws that go into this, and we're being asked. I'm being asked to do the TEE and show you that you're going in here and not the leaflet or not something else. And then mitral line is sort of mimics a K annuloplasty, which all our surgeons say doesn't work. So I don't know why you would do that. And then guided delivery system made something called AccuCinch that goes behind the cords and tries to pull the ventricle together. It's a smart idea because we know it's a disease of the ventricle, but I've seen them rupture cords and make the MR worse doing that. This is the cardioband. You can see what happens. You try to get this first anchor at the trigone, which is over here. They missed. They're actually below the lateral commissure. If you miss, this isn't going to work. It's going to be a band. And it's very hard. And with TEE, you're trying to look at 3D and you're trying to make sure this screw is going into the annulus. I went to Germany and watched Karl-Heinz Cook do this. Rob Smith and I, our surgeon, we went and we weren't being proctored, we were just observers, and it took them 4 hours to do this. I mean, this is brutal. And I was talking to John Webb the other day after a Edwards advisory meeting, and John is as good an interventionalist as there is. He says he quit doing them because he doesn't have time to do 4 hours on one case. He's going to do something else. And I thought that was genius, actually. This is what it looks like when it's in. The beauty of it is, once you get it in, you can cinch it down and adjust the size of it in the beating heart while you're looking at MR reduction. Unlike surgery, where you've got a flaccid heart, it's open, and you're using a sizer to pick the size, right? This is physiologically adjusted. But the caveat to me is the CTSN trial. Best surgeons in the country doing fixed rings, recurrence rate of 58.8% at 2 years, 32.6% at 1 year. If that's what annuloplasty does in functional MR surgically, I can't believe doing it with a transcatheter approach is going to be better. Because I think that's basically, you're treating a tenting disease with an annuloplasty. It's not the right thing to do, So I think, I'm not a big believer in those. That's my bias, but you'll hear other people that are big fans of this and love doing it. I'm going to talk a little bit about TMVR. These are the replacement devices. I have been involved in the TEE guidance of these. Our surgeon, Rick Hebler, puts them in. So we've done Tendyne, we've done 12, I know you guys have done 12 here, I think a lot of them. We've done cardiac Q, including transfemoral. There's also Sophia, Neovasc Tiara, M-Valve, and about 20 others that I'm not showing. Basically, they're similar. They're all different designs for the same thing. And the thing that we know from the stent world is over time, the engineers make these things better. They'll always get smaller and better over time. But they're not there yet. Right now, those valves are huge. And the problem with them is we do these CT scans, and we look at the trigones, which you can see very well on CT. You can't really see them on echo. We can measure the intertrigonal distance, the intercommissural distance. We can do all these measurements, but we're really looking to put a simulated device in and see, is there room in the LVOT, or are we going to occlude the LVOT with the device? And a lot of times we find that we can't put these devices in. So, in our experience with the Intrepid device, for every patient we put in, they turned down 7 because the device wouldn't fit. So right now, these devices are cool, interesting, but they have technical problems. So this is a Tendyne. This is one of our surgeon's finger at the apex. It's very important during these procedures to get the trajectory right. If you get this wrong, you can cause a VSD, right? Or you could have this thing canted, toward the septum or too much to the lateral wall. You could mess it up. So you got to get the trajectory right. Once we put it in, and this valve is really easy to put in. This is what it looks like. It's got a D shape across the curtain here. It's got a 29 millimeter bioprosthesis porcine pericardium in the middle. This is what it looks like on echo with X-plane. You can see how big it is and how close it comes to the septum. It's very close, but this patient did not have a gradient, and that patient actually has done well. We challenge them with, we jack up their blood pressure to look for PVL, because PVL in the mitral position is usually associated with hemolysis and poor outcomes. So the challenges for all these devices, but especially for TMVR, is the mitral valve is much more complicated than the aortic valve. You've got mitral annular calcium, which is common. I mean, I think we sometimes joke our mitral valve clinic has become MAC clinic. We get all these 80-year-old ladies with severe MAC, and they're sick, and none of our devices work, and surgeons don't want to operate on them for obvious reasons. You've got large device profiles. I've seen one device that I really like, and I'm supposed to go to Israel next month and play with it, in a pig, and it's 15 millimeters tall, so it looks a lot like a Edwards Magna-Ease, and the operating system is like a MitraClip, wireless, no wire needed, steer right down to the valve, put it in. You have LVOT obstruction and SAM. You have anchoring issues. How do you anchor this valve safely so that it doesn't come loose? Paravalvular MR and hemolysis, device thrombosis, and then each device is different and has different imaging needs for guiding it into position. It's very complicated. But I think there's a possibility for this. And if you think back to the CTSN trial where replacement seemed to do a little bit better than repair in terms of durability, TMVR theoretically eliminates MR, but the clip only reduces it. So the hypothesis that we need to test is that elimination of functional MR with TMVR is better than reduction of MR with the clip. In other words, can those COAP patients do better if you totally eliminated the MR by replacing the valve? The problem is safety. Remember I showed you that 97% safety bar for the mitral clip? If you're going to do TMVR, you have to cross that bar. And that means it has to become transfemoral transeptal. It has to be a 24 French or smaller sheath. It's got to be steerable and easy to do, like the mitral clip. And right now, I think transapical TMVR is dead in the water. Dead in the water after clip. Who would do that when the clip shows a safety profile? So I'll stop there to say the biggest complicating factor for TMVR and all these devices is the COAP trial. It just threw a monkey wrench into everybody's study. Thanks.
Thank you, Paul.
Questions? That's what I was at the COAP party, so I was partying, but with the rest of the team. But yeah, I heard it was gloomy, and you know, there was black crepe hung from the walls and all that. I mean, does anybody disagree and think that there's still a role for transapical TMVR? Mike?
There might be. The question is whether it's worth the business investment of billions, because there's probably still a group of patients that anatomically the clip is not feasible. They may be high risk for surgery, and it would be nice to have that other option. Question is that small group worth the investment these companies have to make?
Yeah, that's a great point. And to me, the unmet need right now is that little old lady with MAC. Yeah. And the problem is they're very sick, and they will die from that if we don't. They're miserable, but they'll also die if we don't fix it. Well, a clip is not even an option. It causes mitral stenosis. Same for a PASCAL. Yeah, right. No surgeon wants to. I mean, it's hard to put stitches in concrete, right? So, and then you have AV disruption and horrible complications when you try to remove it. So to me, these companies, those ladies have small ventricles too. Remember I said the devices are like a beer can? What they need to develop is a small profile valve that will sit safely inside of MAC, an anchor in there, not protrude down into the LV, so that we could at least offer palliative help to those people. And it has to be transeptal, transfemoral, small. That's where the companies need to develop something. They're far away from that right now. The valves are too big.
I would take a transradial, transeptal, stay away from apex. I just stay away from, I think you're right. TA is dead. It's dead.
Yeah.
We're wasting our time. This is a long discussion I've had with some people at that time. And transfemoral, transeptal is the holy grail, but you know what? You pointed at mini invasive mitral valve repair. They do really well. You can do a minimally invasive all pump by going right at your. We've done 24 of those.
Rob Smith has done every one of them. You know, minimally invasive, right atriotomy, go right in like he's doing a mitral valve repair, and puts a safety valve in the MAC. He puts, if it's really irregular, he puts felt across the bottom of it to prevent PVL, and then he puts a stitch in both trigones to keep it from flipping out anteriorly. And we've had very good results so far. We have had a couple of patients get LVOT obstruction. We've had 2 deaths out of the 24, but we've had a bunch of successes. So we're still in the learning curve. We've also done, I'm sure you guys have too, some sapien valves transeptally in MAC, and that literally scares us. We have to wear lead depends in the cath lab when we do that. It's scary. He's the PI. Yeah.
So that's what we're working on, trying to get that up and running here. The problem is that if you just do these as cases, and they go poorly, which they will.
They will.
They go to your hospital QM, And you know, and then somebody says, well, why in the world did you do this? And so it's really hard to do these without doing them in some sort of trial format where we can actually learn something from it.
Yeah, I agree. So I'm excited about that, and I'm excited about the trial. I think the hardest part for us, whether it's TAVR or this or any mitral, is the patient that we can't help. You know, it's so easy to say, we're going to put a TAVR in you. That's a 15-minute discussion. When you start talking about there's nothing we can do, that's an hour-long discussion. We have to bring the hospice team in. It's difficult. Oftentimes, this is the first time anybody's told the patient that they have a fatal disease and their outcome is terrible. And so those can be the hardest thing you do in valve clinic is to learn to say no, when to say no, and to be able to say no gracefully. Very hard. Thank you.
Thank you, Paul.